good morning, good afternoon, and good evening, depending on wherever you are. Welcome to session number 53 of our special COVID-19 series. It is a series that we have dedicated to diagnostics in the COVID-19 pandemic. And today we are going to be talking about an important topic as usual with regards to the pandemic. Maybe to give a few logistical notes before we start. This is going to be 1 hour long, which is going to be made up of a couple of presentations, followed by a question and answer segment. So today we would like to keep on. It is 2 years after the pandemic was officially declared. And 2 years, we have lost about 500 million people. In the same 2 years, we have almost lost about 6 million of our beloved ones. As you can see, just like the WHO Director General, Dr. Tedros mentioned, I think a few weeks ago, this pandemic is not over anywhere until it is over everywhere. Although many of the countries are recording declining numbers of cases, but as long as we still have a number of cases out there and that threat of new variants still there, the war is not yet over. And this is one of the main reasons why we are here today. My name is Anafi Mataka. I'm from the African Society of Laboratory Medicine. I act as a project lead and I'll be your co-host today. Allow me to introduce to you the speakers today. We shall start with Dr. Fatim Jallo from the Global Fund, where she serves as the Senior Medical Laboratory Specialist. And we hope to have Dr. Yenu Kibede somewhere along the course of the program. He is not able to join us right now. And we shall also hear from Mr. Silva Mashate, who is a program manager at ASLM, Owen Demke, a senior program manager at CHAI Global, and Lucy Robinson, who will take the place of Ralph Timperi, a senior advisor for laboratory practice at APHL USA. They will present one long stretch of slides, after which we'll go into question and answer. Fatim, I'd like to call upon to you to give us a few opening remarks before we move on.
Hi, thank you so much, Anafi, for that introduction and the warm welcome. And good afternoon and good morning, everyone. And thank you so much for being here. So just a few remarks from the Global Fund, and to note that since 2014, the Global Fund investments in diagnostics and lab systems have been significant and relatively consistent at around 12% of the total allocation to countries. And also noting that the African region is a region where the Global Fund invests heavily in diagnostics and lab systems. So in addition, the Global Fund COVID-19 response mechanism has awarded above 800 million to 100 countries for procurement of COVID-19 diagnostic tools, as well as lab system support. And this represents 27% of the C19 RM 2020 investments. And of this, the majority was also to the African region. So we at the Global Fund do take strengthening lab systems very seriously, and it is critical to our programs as well, and as you all know, to pandemic preparedness and response. And we also encourage investments that would lead to strong integrated lab systems, which are common denominator and critical to integrated and comprehensive people-centered service delivery and care services that are central to achieving global health priorities, including UHC, antimicrobial resistance, and also impact against HIV, TB, malaria, as well as disease surveillance. We need to ensure that the investments, we use them to enhance lab systems to ensure readiness for the next, not just for COVID, but also for the next pandemic. We note, however, that despite these funds, COVID-19 testing rates have remained low in most of the countries in sub-Saharan Africa when evaluated against the WHO or the ACT-A targets. And as recent as November, AU CDC and its partners did launch a bottleneck analysis in the region, and this revealed persistent challenges for effective scale-up, including decentralization of testing to community level, including restrictive national diagnostic policies and lab systems challenges, of which, just to name a few, include HR numbers, resources, data management systems, training and competency of healthcare workers, and also healthcare waste management and sample referral networks, just to name a few. As well as quality systems, of course. So to support countries to achieve the WHO as well as the ACT-A targets for COVID diagnostics, as well as strengthening lab systems, the Global Fund is introducing Project Stella. What is Project Stella? Project Stella focuses to support 23 African countries, which have been proposed and selected based on the quantitative analysis that I mentioned, and also based on the C19 RM allocations in diagnostics and lab systems, which amount to greater than 8 million. And this then represents 70% of the total C19 disbursements in diagnostics and lab system. And Project Stella is with an initial investment of almost $10 million. And the project will be working with ASLM, CHI, as well as APHL under the coordination of Africa Union CDC and its partners that meet regularly in the African region to support integrated diagnostics, but also galvanize longer-term strengthening of lab systems. Specifically, the support would lead to improvement in national diagnostic governance, scale up and increase coverage for COVID-19 testing, and also advocate for and generate evidence for effective COVID-19 environmental surveillance to be used as a tool, an early warning tool to inform public health social measures. And finally, strengthen data management systems and integration of COVID testing data into national lab information systems or health management information systems. As we support scale up of testing, the Global Fund is also supporting, in collaboration with other regional partners, strengthening of quality management systems through establishment and institutionalization of regional capacity for COVID-19 external quality assurance schemes, as well as ensuring integration of COVID-19 PT schemes into existing national PT schemes. In closing, I want to mention that at the Global Fund presently, we are at critical points. First of all, countries are currently in implementation phases of this the current funding cycle. As well, this is a period for portfolio optimization, which is a period in which savings are identified to support activities that were originally not funded. So this is a huge opportunity to fund lab systems gaps, and I would encourage all lab leaders to discuss this with the CCMs. This is also a replenishment year for the Global Fund, and as well, we're preparing for a new funding cycle, the NFM4. And also finally, we have a new Global Fund strategy that was recently launched, which emphasizes a fundamental shift in service delivery such that services are integrated and focused on the needs of peoples and communities, which was recently launched. We want to ensure lab leaders are empowered and be involved in key decisions regarding integrated lab systems, and in the development of robust funding requests that I just mentioned would be starting soon, and that these funding requests should articulate gaps and priorities in lab systems. Support is available from the Global Fund to assist countries prepare for the next funding cycle, and I urge you all to use this. With that, I will end and hand back to Anafi, and thank you so much to the Global Fund, CHAI, APHL, Africa Union, CDC, WHO, Afro, and all the partners in the region. Thank you. Over to you.
Thank you, Fatim. I join you in thanking all those partners as well. Colleagues, to take us what the planned strengthening COVID-19 diagnostic and laboratory systems investments in Africa through partnership project Stella entails, I would like to call upon first Mr. Silva Mashate to take us through the first bit of the presentation. Silva, over to you.
Thank you, Anafi, and thank you, colleagues, for this opportunity. And thank you so much, Fatim, for the very well put forward preamble to the project Stella. And you did actually more than 50% of the first segment of this presentation. So like Anafi has mentioned, colleagues, my name is Mashate Silva. And I would like to highlight that in the presentation we are going to have providing overview of the project Stella. We have a couple of slides here, but this is work comprising of a wide range of stakeholders. You will notice that we have put together a lot of pieces of work from different stakeholders. So we appreciate the support from the Global Fund, and particularly from the AU African Union for all the support that has made this possible. So Fatim has given us a very good preamble to this, and I will just emphasize this with the visuals, just indicating that accessibility to quality diagnostic testing is actually very key when you respond to public health emergencies like COVID-19. And this was very well put forward by the head of the WHO, Dr. Tedros, where he emphasized that effective way of preventing loss of lives to this pandemic is actually through testing and testing and testing. So as part of the response in terms of laboratory testing services, we know that these provide very important information for breaking the chain of the transmission, most particularly for epidemiological surveillance, and this helps countries to be able to take public measures and preventive mechanisms to ensure that we don't lose any more lives. And for us to be able to do this, we need partnership, support, and funding to ensure that all these things happen. And there's no better way of saying that Project Stella has actually come at the right time. And Fatim already put a very clear background to this, that towards the last quarter of 2021, the Africa CDC through partners and AFTCO actually conducted a detailed bottleneck analysis, and it came up with a wide range of bottlenecks that are affecting access to COVID-19 testing in our communities. And these were many, and they were blocked into initially the 5 areas, which involved planning, where some of the member states didn't have the necessary regulatory mechanisms and governance guidance to ensure that testing happens in the countries, the issues of product registration. Procurement and supply chain has been part of the systemic problem in our healthcare system, and it remained in there, affecting this access to testing. But even in some countries where we had resources, we had the kits, and even we had the strategic guidance, there are limitations in proper implementation. You discover that some areas that had the kits, had the supplies, but still access to the services was low. And then this, of course, data management remains an issue. And the bigger problem is that community access at that community level, the last mile, still we are having few people accessing these services. So through partnership, through Global Fund, made all this and further refined this to what Fatima has already highlighted, that the Global Fund finally prioritized all the several bottlenecks that we identified and came up with these 3 block areas, which we are calling the real drivers of poor testing: the issues of governance and policy, limited resources, and then data management. When it comes to issues of governance and policy, the issues of not having kits registered, as earlier mentioned, were some of the issues that were identified actually at national level. Because our healthcare system has actually tiered in a way that you begin from the national level all the way to the last mile at the community level. If you don't have governance structures properly at national level, then it means these other factors at the community level will be affected. Having given this background, now we look at what the project Stella actually ignited to happen. Fatim mentioned this, that Global Fund is actually one of the key partners that's supporting this response. And she mentioned already about the 800 million that has already been provided to respond to COVID-19. And these are some of the top 20 countries that are receiving the funding. Here we have the amounts of the funds received in terms of USD million dollars. But the interesting or the most critical part about this slide is that none of these countries was actually meeting the set targets that we are working up to. The ACT targets were not being met. So this means, yes, the funding is happening, but what is happening? And this is what Project Stella is coming up to do, to focus on these areas, improving national diagnostic governance and regulation as the first area. The second one is to ensure that we scale up and increase coverage of testing and surveillance in our communities, and then strengthening data management systems. To do this, we need to get a clear picture that Project Stella, as we start, may not be in all the 55 member states. It's going to focus on strengthening laboratory diagnostic systems, but will be in 30 countries. And as we speak, as of today, 22 of the 30 countries are actually known, and Global Fund will be letting us know as bottleneck analysis continues which other 8 countries will be considered. And important to note is that the 3 partners who are going to drive this, as earlier mentioned, is the African Center for Laboratory Medicine, CHAI, and APHL. This project is here up towards the end of next year. And colleagues, from this point is where we would like now to open up the discussion for each of these partners to clearly tell us what exactly they'll be doing. But before they do that, these are the 3 intervention areas that we'll be addressing. The first intervention area, which is intervention 1, is strengthening governance and leadership at the national level, and then scaling up testing in areas without community testing. I think this is important for us to know that there might be testing in some parts of the country, but some communities completely lack this testing. And this intervention 1 will be led by CHAI. The second intervention area, which is increasing coverage in area, will be insufficient testing and supporting data management systems, will be led by the African Society for Laboratory Medicine. And the third intervention, which is about water-based surveillance, will be led by APHL. So from this point, I would like to call on our colleagues to pass on the information and explain to the stakeholders how is CHAI going to implement intervention 1. So allow me call on our colleague, Owen or Dominique from CHAI, to briefly let the stakeholders and explain how CHAI plans to roll out and support implementation of intervention 1. So Owen, please, you're welcome. Take on the floor from there. Thank you.
Great, thank you, Silver, and thanks Anafi and Fatim for the introductions on this. So as Silver mentioned, there's 3 different interventions under the Project Stella work, and CHAI will be leading the intervention under intervention 1. And as Silver highlighted under intervention 1, this is broken into 2 different interventions. Intervention 1A focusing primarily on strengthening diagnostic governance and looking at the policies that are in place and ensuring that those policies are in line with national and global guidance and the evolving pandemic as we've seen it change over the last few years. And intervention 1B, which is focused more on scaling up of testing, particularly thinking about community-based testing, but just expansion of testing more broadly, and especially into regions or settings where overall testing coverage remains limited. You can see here a mapping of the countries that are listed as a part of these interventions and exactly which countries are receiving that TA support. And on the right side is a summary of the consortium roles and different entities that are a part of this work. So again, CHAI will be serving as consortium lead, focused on some of the grant management oversight of the overall intervention, as well as a direct implementer and of the TA support in specific countries. So that work will also be in line with ASLM as a consortium partner. ASLM will be providing a lot of the regional support as their experience has well prepared them for around training support and M&E tools, and a lot of that work that will be set out for countries. And then at the last piece will be a few entities being subcontracted under this work for specific country technical assistance, and this will be different entities including PSI, Selena Health, AMREF, and then Health Poverty Action for support on the engagement with communities as we think about the community level engagement and community level testing expansion. Next slide, please. And here is a summary of some of the proposed TA work areas that this Project Stellar support is intended to align with. I just want to step back to something that Fatim said earlier and Silver highlighted, is that these TA work areas are really intended to align with both the priority set out in the Global Fund C19RM request and the work and the priorities that ministries are setting forth. So these different TA work areas are really intended to be further defined over consultation with country stakeholders as these engagements continue. But they expand across a few different areas: decentralization of testing, improvements of strategies, thinking about multi-disease testing or the role of self-testing as that comes into the market, looking at task shifting and being able to activate non-lab personnel to increase testing coverage, community-based testing, as we've spoken about to a good degree, activation of different settings there, M&E, and then finally looking at improvement to the PSM and procurement and supply chain systems that are in place so that we minimize stockouts, we have the right products at the right places at the right times. And you can see on the right some of the deliverables that are highlighted here. I won't go through them in detail, but really just intended to demonstrate some of the goals of this work. And again, it's really structured in a way that is technical assistance aligned with the funds that are already coming in through existing C19RM support, and to align with the work the ministries are already putting forward, and so that we can achieve some of these strategies and initiatives to ensure that COVID testing is still expanded, is used in the right ways, and as efficient as possible. So I'll stop there. I can hand it back to Silver for the next intervention. Thanks.
All right, thank you so much, Owen and colleagues. That is how intervention 1 is going to be implemented and the partnerships. So we now look at intervention number 2, and this intervention number 2, as earlier highlighted, is going to be led by ASLM. And it's also split into 2, where we have the first part, which is intervention 2A, regarding increasing testing coverage in areas with insufficient community testing. And here we are meaning that we know that the transmission could be happening in the community, but how do we ensure that if people don't come to the community, how do we reach them in the communities where they are staying? And then the second bit is the issue of data management. So as highlighted in the map, intervention 2 is going to be implemented in about 18 countries, among which one of the countries, that is Uganda, which is actually highlighted in green, is one country for intervention 2 that will be receiving both interventions 2A and 2B, while the rest of the countries will be receiving one of the interventions. For example, those in yellow will only be receiving support for intervention 2B, which is in regard to data management systems. And then this highlighted in brown color, will be supported for ensuring that to increase testing coverage in those areas. This work is going to be based on a consortium of partners, where we're having ASLM as the lead managing the grant and provides the overall regional support. And CHAI comes in here to provide consortium support as a partner at the country levels. ASLM and CHAI have had a long partnership in COVID-19 response. And here we see that CHAI has representation in many of these countries, is on the ground, and therefore is a good partner for us to work with. We have a very important partner from Botswana, that is the Botswana Harvard AIDS Partnership. This is an organization that is in Botswana, doing a lot of work in the COVID-19 response, and will be part of this and will be leading, supporting the implementation of this intervention in Botswana. Previously, ASLM has continued to do good work with BHP. And this work will have subcontractors, with some of them coming as civil society organizations who are closer to the community, Solina Health and Health Poverty Action, to be supporting in some of these countries. So this is the partnership. The consortium of partners will be implementing this intervention, and those are the countries where I will be going. Just like earlier mentioned by Owen, we have proposed priority areas that we'll be focusing on because we are looking at increasing coverage of testing, data management systems, and these are some of the areas that we feel we'll be working on. On our extreme left, we have the proposed work areas because we feel if we are to reach out to communities, then we need to decentralize testing. The priorities we need to ensure that we implement such that testing reaches the communities. One of the gaps that was identified during the bottleneck analysis is the issues to do with capacities of human resources, the competencies. We feel these are areas that will work with the countries, issues of supplies, and then community-based testing. So community-based testing, we know that initially when the pandemic started, testing has been happening in labs that are well established with PCR or the nucleic methods. And therefore, reaching out to the community, the World Health Organization gave us a guidance on how and ability to use the antigen RDT. So we'd like to use this intervention to see that how do we reach our communities, and then the M&E data systems. And we feel, together with partners under the leadership of the Africa CDC, that if we are able to implement all these priorities, depending on the country's specific needs, we will be able to achieve the expected deliverables of reaching the intended targets and increasing the proportion of our communities accessing these services and to be able to report the data. So this is how we'll be approaching intervention too in the different countries. And we need to realize that there are additional countries that we're expecting that will be added to benefit from this support. So please allow us to call on our colleague Lucy from APHL, who will now take us through the intervention 3, how APHL plans to support the different countries in implementing this intervention. Lucy, over to you to take people through intervention number 3. Thank you.
Thank you so much. So for APHL, the Association of Public Health Laboratories operating out of the US, we represent government labs doing testing of public health significance. We'll be supporting intervention 3, focused on wastewater-based surveillance. So that really is the strategic sampling and testing of wastewater to detect either pathogens or other health targets to better understand disease burden, but also the spread of disease within a community. So as part of the intervention 3, we'll be looking to create enabling policies, but also specifically working to implement pilot surveys as a tool to inform COVID-19 public health response. And remember, this is still a threat, even with diminishing numbers in certain countries. We do not want to let down our guard. So wastewater-based surveillance has been used primarily from a historical perspective for polio, with probably over a 40-year track record there. I think Nigeria was one of the early adopters when it related to that, but it is relatively new when it comes to its use for other diseases. Here in the US, we're really seeing wastewater-based surveillance taking off thanks to COVID, and the National Wastewater Surveillance System was also established in 2020. So we now know that wastewater-based surveillance is a critical early warning indicator to new potential hotspots. So we use it as a surveillance tool. It gives us that advance notice, not just for the sake of knowing it, but for public health intervention. So giving us that early warning prior to disease, to hospital-seeking behavior. It also helps us build infrastructure for future pandemic response. And frankly, from a cost-effective perspective, it really is advantageous for surveillance. So this is particular value in communities that may be seeing a delay between specimen collection and reporting of results, and we're able to glean infection dynamics with considerable advance notice for action. I think things get even more exciting when we look at pairing wastewater-based surveillance with genomics. And that, as we look to the future, really allows us to look at sequencing for pandemic preparedness, looking at other diseases, looking at its value for antimicrobial resistance, environmental contaminants, vaccine preventable diseases, and a whole host of other uses. So we're really excited about what the future bears for that. In terms of Africa, we have definitely seen its value with studies performed in South Africa through the South African Medical Research Council and the association there. So we think that will be a great value. Next slide. So in terms of our focus specifically, we will be implementing these surveys in 4 countries: Ethiopia, Kenya, Mozambique, and Uganda. So we will start off with some assessments to inform supply chain planning, which we know is a huge issue for lab at the moment, but also leveraging existing platforms within the countries for wastewater-based testing. We will be developing testing protocols that are validated within each of the respective settings, making sure they're appropriate. We will establish a community of practice between the countries and the labs performing this testing. Like I said, this is relatively new, especially as it relates to COVID. And so as we all move towards harmonization of best practices and protocols, this will be an invaluable asset for the work. And we will also be looking to really scale up testing. This project will go through 2023. Data reporting will be key to this work to ensure that we have access to the data and be able to analyze it and produce actionable information for public health response. Stakeholders will be engaged in all levels of this, including establishing testing policies. So as countries consider expanding wastewater-based surveillance within their countries, we will have the right players at the table for that consideration. The data management and interpretation, as well as sampling strategies, will also be considered as part of this effort. Finally, I'll just touch on sustainability, which is going to be front and center in everything we do here. The idea for these pilots is to really have this be a proof of concept nationally and hopefully expanding it to other countries. So we will be using twinning with our seasoned labs that have been doing wastewater-based surveillance for a while to provide support, to provide training, workforce development, and system development for wastewater-based surveillance. Thank you. I'll pass it back on to you.
Thank you so much, Lucy, for that. And that is the intervention implementation strategy for APHL. And colleagues, having listened to this, we now look at some of the risks. We know that as we go to implement Project Stella, as we come out here to engage stakeholders, there are a couple of risks and assumptions out there that we appreciate and we know do exist, because we've been working with the communities, we've been working with the partners. And one of the issues that we know that, and I think Fatim clearly explained this, that the dynamics and the evolution nature of this COVID-19 pandemic actually influences so many country priorities. This is an illustration of one of the datasets from one of the countries where you see that these waves very much affect how a country can receive an intervention. For example, this is data from Botswana where we had a surge here where we see that that's the time when Omicron was actually identified around that time. So given that it is not consistent in terms of the prevalence across the time, that can actually influence, and it's a big risk on how we can actually be successful in this project. And the potential emergence of new variants, we got Omicron, we have got the Delta versions, we don't know what the future holds for this virus. So as we go and come out to the stakeholders, we are aware of these risks, but we hope we'll be able to build systems that actually will meet these challenges. The other risks that we appreciate is that as the pandemic changes, as things happen, there have been lots of travel ban lifting of the restrictions. When we see the media, we are now allowed to move from one part of the country to another. We have seen in the media where different countries have actually changed the guidelines and the travel requirements. So recently we saw in the media what has happened in Kenya, in countries like Zimbabwe, where the government is saying, well, if you're fully vaccinated, you can actually come in maybe without the vaccination. So what does this mean, the intervention of COVID-19? It means we have to be alert. There's a bit of relaxing of these restrictions and they have impact and meaning to the intervention. When we come to other things that are happening in our communities, These are risks that we need to take care of, and this means at the takeoff of the project, the fight for this against this pandemic, there are issues to do with political unrests and possible insecurities. Some of our sister countries, as we speak now, we are having refugees moving from one part of the country to another. And when you're having refugees running away from war, this is an influx of communities that have come. At that moment, a government may not be having the kits. And as they move, they are moving in groups. So if there's anyone who is infected, the transmission rate pattern will change. Okay, so all these are some of the risks that we are anticipating to happen. But hope is not lost. We have so many opportunities out there. For example, we have lots of support from different partners who are supporting this, mentioning Global Fund, and among others, we have WHO. We have the support from the Africa CDC. All these are opportunities that we can tap into to ensure that we fight and control this pandemic. There have been a release of new guidance allowing self-testing, released by the Africa CDC, released by the World Health Organization. These are opportunities that we can tap in to see that, well, if we have guidance and ability to take tests in the community, how do we leverage on this to ensure that we fight the pandemic? There's a new concept of vaccination. We know that it's still low on the African continent, but we are confident over time it will also play a role in ensuring that we tap into it to ensure that we fight this. The other bit is that we already have some existing lab systems in the countries that we are going to leverage on. We need to re-emphasize here that as we come and start implementing Project Stella, we appreciate that there are so many other partners on the ground who have been supporting these interventions. Systems are in place. Project Stella is going to work to strengthen and improve this. We are not coming to destroy the systems, but to work and support and improve them such that, like Lucy mentioned, we use this opportunity to prepare for upcoming pandemics and ensure that our communities receive the best. The other opportunity that we see that we can build in is the growing local capacities of some of the labs that we have. For example, we know the story of Omicron that was first identified by a laboratory on the African continent. I think these are some of the things that we need to benchmark and build on such that we know that there is hope at the end of the future, at the end of the tunnel. So colleagues, as Project Stella comes over, we seek for stakeholder support. We appreciate what is happening, and ASLM, CHI, APHL, and all the other consortium partners under the stewardship of the Africa CDC and Global Fund will be able to implement and ensure that we implement this. So this is our last slide. Having listened to the story, what next? How do we plan to implement all this? Colleagues, this implementation for Project Stella is going to be phased, and it will have 3 phases. The first phase is entirely involving stakeholder participation, engagement. What we are doing now is one of the steps we are doing to make sure that the partners are aware what we are coming to do, the how, and we earlier mentioned that for each of the proposed interventions that we are planning and think about will be dependent on the in-country deep down analysis we shall conduct to identify country-specific priority needs, and then that will drive us into phase 2, where we are going to develop the specific country work plans. These work plans are going to be developed in collaboration with the Ministries of Health, the Ministry of Health COVID-19 task forces, the COVID-19 lab pillar, the lab pillars in the country, including all the other partners who have been in the country implementing response to COVID-19 since it started in 2020. And we have timelines that we've proposed, where phase 1, we are hoping to do it by the end of April. We should have finished that phase. And then the second phase by end of May should be starting. And then phase 3, where we are going to get our hands dirty, implementing the work plans, and we'll be trying to monitor this. We earlier mentioned about the expected deliverables. We'll be supporting the M&E systems to see that we implement the work plans that we have actually put up with the communities. And hopefully by the end of 2023, we'll have made a contribution to increasing community access to COVID-19 testing in our countries, and also strengthening the water-based surveillance and data management systems. So colleagues, we would like to stop here, but we appreciate all the partners who have continued to make this possible. We respect all the colleagues who have suffered through this scourge, but we continue working together with partners to see that we fight this pandemic. So I'd like to stop here for now and hand over to Anafi, please, for the next part of the session. And we encourage you to provide any comments, any questions. And thank you so much, everyone. Back to you, Anafi. Thank you.
Thank you, Silva, Owen, and Lucy for sharing with us the plans for Project Stella. Colleagues, I would like to go on and take on the questions that are coming in the chat. Please keep them coming. We shall take them as we go. Let me pick the first one from Amina from Cameroon, where she is asking, what are the country selection criteria for the project? We see that she used her own country. Cameroon is not included, but as a blanket, would you, any of you, maybe speak to the selection of countries for the project?
Thank you, Anafi, and hopefully let me go first, and then hopefully Fatim will chip in, or Owen. So like we earlier mentioned that in late 2021, the Africa CDC through the AFTCO actually conducted bottleneck analysis across many countries, and a list of gaps were actually analyzed, and based on that, the countries were also prioritized depending on what the data showed. And after doing that, not all the 55 African Union member states were actually at the same level of need. Some of them were actually doing badly, others were better off, and the different parameters were used. Some of the parameters, what is the testing ratio? Are we meeting the targets? How many sites have been activated? In which wave of the pandemic is in this country? And many other factors were considered. And based on that, the countries were actually prioritized, and that is how the selection criteria came to choose those countries. And like we highlighted, you realize that Project Stella is coming to support 30 countries. Sorry, yes, 30 countries, but so far we have 22. And that means that as more gaps are identified, some countries will come on board. But we also indicated that one of the risks and the challenges we have with this pandemic is that it is evolving every day. The picture which was at the end of 2021 in some countries is not what it is now. So some of the things have changed and they guide that. So enough, maybe I stop here and request maybe Owen or Fatim if anybody has a comment make on that, but that's what you could say for now. Thank you.
Thank you, Silva. Yes, thank you for giving perspectives from the AU bottleneck analysis. Maybe I can call on Fatim to speak from the Global Fund perspective.
Hi, thank you. Yeah, thank you so much, Silva, for that. I just also wanted to add that the selection also involved selecting countries with high C19RM investments in labs and diagnostics greater than 8 million. So in addition, Cameroon, for instance, at the time of the bottleneck analysis and up to recent, have been meeting the WHO targets and actually close at some point to meeting the Act 8 targets. So we congratulate Cameroon for the great work. And so for now, Cameroon was not prioritized. However, like we said, even though we're going into support COVID-19 diagnostics, we will leverage Stella to actually also support and advocate for integrated diagnostic, not just for COVID, but for other infections, for instance, HIV, TB, malaria, and as well as others down at the community level, and also support lab systems. So it's not stopping. We're using COVID, but we're not stopping at COVID. Over.
Thank you, Fatim, for the response. I would like to take the next question that is coming from. I've lost the question, but I still remember it. I think it's from Njoki. This project is aiming to increase coverage of testing, and she is asking, what will be the role of PCR in all this? Maybe,
thank you so much. I'm not sure we should go first.
Yeah, you can go ahead.
Yes, thank you so much. So Project Stella is not coming to swipe or to sweep away PCR. And Fatim put it very rightly that Project Stella is coming to complement the existing interventions that we have. Complementing means, from the science point of view, we know PCR COVID-19 testing is the gold standard. It has so many numerous benefits, But among the benefits, there are also limitations that, for example, a person who is in a peripheral site may not be able to access the test immediately, or to take a longer time. And that's why you have another opportunity that has been approved by the World Health Organization of using the COVID-19 antigen RDT. So antigen RDT, from the application point of view, is easily applicable at community level, and therefore comes in to complement the already existing PCR platforms to increase access to the communities. The other thing that we need to highlight is that when we talk about communities, we are not only talking about the colleagues or some of us who are in very peripheral areas of the countries. Even people who come to the health facilities, they constitute the community. But quite often our health-seeking behaviors are that we go to health facilities because we are feeling ill, we are feeling unwell. But we are saying, how can we reach out to test people who are asymptomatic and possibly have the infection? We need to reach out to them. It might be more difficult to carry a PCR machine, for example, to a school or a prison, but it might be easier to go with another platform. And therefore, the facility reaches out to the community using the mechanism within the country under the national guidelines, and then offers the service, and that's what we need. So I would stop there for now to allow other colleagues also to make a comment. Thank you, Anafi.
Thank you, Silva. Owen, would you like to weigh in?
Great. Yes, thanks, Solar. And I agree with what Silver's comments are about the complementarity of the two systems. And I want to stress that the role of the overall goal, right, is to increase our testing coverage as much as possible and get as much visibility as we can into spikes in cases where they're appearing, and also to think about where possible to even do bidirectional testing, where someone can come in with symptoms and we can actually dually diagnose either TB or COVID, or let's say even malaria. And so now PCR has its role, as Silver has outlined, but where we're going to see, I think, the most impact from mass deployment of antigen testing is as we have the ability to activate more testing sites, so people don't have to go to a regional hospital for screening, but are able to get tested in their district or in their cell. And so we've seen, like in Rwanda, where all of the health facilities have been activated to provide COVID testing. So any facility you go into, you can get access. We've seen out into the community in the ways that, like in Cameroon or in Ethiopia, where as larger events or mass gatherings have happened, we've been able to do rapid testing in a way that mass amounts of people have been screened, have had access to testing that didn't restrict the use of those PCR platforms and the timelines to get the test back. And we also have to take this all into the perspective that the PCR devices are also being used for HIV testing, are being used for TB testing, and we don't want to risk impacting those other disease areas by overwhelming the capacity on those existing platforms and leveraging the resources that and the ability that these antigen tests provide, and those rapid results, the cost effectiveness of the results. So we have to think about it in all of those different characteristics. Obviously there's gaps, but I think a lot of the work that a lot of you all on this call have been doing is intended to help think about how these two strategies, these two technologies can be used complementarily with one another. Thanks.
Thanks, Owen. Moving on with the questions, I think I want to pick this one from Dr. Radiet Alemu, and I think this will be best answered by Lucy. She says, she or he says, what is the criteria for selection of countries? We have answered that part, but she wants to know what is the contribution of public health and animal health laboratories in this project? Lucy, are you able to take that from the perspective of West Coast border-based surveillance?
What is the contribution of, can you repeat that, Anafi?
Public health and animal health labs.
Yeah, so public health labs, and I saw another question also after that around surveillance and commingled sewer networks, and so maybe I can tackle both of those at the same time. So public health labs really are at the forefront of this. And, as mentioned, really our focus for this project is on COVID-19 and that early warning system. So from a surveillance perspective, it really comes into play when we have a lag in reporting. I will say it's going to be really critically important that when we're using this as a surveillance tool, we are matching up this data with other data points as well, including things like hospitalization rates and positivity rates from the clinical side of things. So it's really about monitoring that trend and informing public health decision making. And it really is certainly here in the US, the public health labs that are at the forefront of that. And then, as we're looking also at genomic testing and pairing that with wastewater-based surveillance, when we're looking at tracking of new variants as an example, that becomes also an asset as we are seeking to stay ahead of whatever the new variants are that will be coming our way. And I think the other critical piece here becomes the modeling, meaning the data interpretation, the analysis, and the decision-making on the back end of this, which is also tricky to do, especially when you have commingled source systems. And that's going to be one of the areas we're really looking at for these settings. A lot of that wastewater testing here is done in different environments, including, settings like university settings. And so we're going to have to figure that out for each of these countries and what makes the most sense from the sewer systems that are in place there.
Okay. Thanks, Lucy, and also for touching my next question, which was some of the key, you mentioned that in South Africa, there were some 5 provinces where some studies were done, and it would be interesting to just get a snapshot of what were the findings in terms of really how this surveillance is working. You touched a bit on that as well.
Yeah, so the South Africa study, and I can also share with you and happy to share with everyone some of the data that came out of that study, and I'm happy to put it in this chat as well. So they started off in limited provinces and then expanded out the Western Cape, Eastern Cape, and additional ones. So I touched a little bit on the challenges they faced around the collection of these samples, ensuring that they were kept properly. The sample referral system and transport system was of particular challenge there. That being said, they did find that it was extremely valuable to have these early warning systems in South Africa, and it did work pretty effectively and continues to do so. It's also relatively low cost and efficient from a perspective of surveillance, so not having to engage a patient to get at this data. And so we're seeing it really can be of value, and I'm happy to put in the study report in the chat or to share with you, and happy to share with the audience.
Thanks a lot, Lucy, for that. We're looking forward to receiving that. I want to take this question. I think Lucy has also spoken to the issue of sustainability, and I think many of these questions are doing so. And I think Marguerite has quite put it in an interesting way. How do we see this moving forward? What is the role of national entities to ensure that we have sustainability? I think to put it in her words, she says, how can we ensure that COVID-19 will be integrated back into the routine ID SR, as most of the COVID-19 specific coordinating mechanisms and their dedicated HR and financial resources are currently being rolled back in many of our African countries. She says also it will be key to ensure that a transition is enough. Also considering, I think, sentinel testing volume can still be performed as part of the routine testing activities of other diseases and effective reporting channels. Maybe a comment towards that. Particularly how, yeah, okay, please go ahead.
So possibly the best way to approach this is that one of the approaches that we have proposed that will be working with the countries, the fact that we'll be working with the ministries of health, we said we'll be working to ensure that we support integration of COVID-19 testing in existing systems. For example, some countries already have specimen referral systems. We have mentioned about the bidirectional testing, where we have ensuring that testing happens in the routine clinics. We know this has a hinge on the already burdened healthcare facilities, the few personnel that we have. But as we work with what we have, one of the issues that we are raising is that how do we strengthen staff competencies to be able to perform this? And this actually helps us to explain why, again, the benefit of antigen RDTs comes into play. Owen earlier mentioned that the PCR platforms are actually being used for HIV, for TB, and the other tests. Now with COVID-19, I think this also is going to be beneficial, that given that this is possible to do an RDT, then it means we can have these people trained who are in these clinics to ensure that they look at it as any other disease. And we need to remember that many countries now are coming up with home-based care management options. So time has come where COVID-19 in some communities is not a threat that people like it started in the beginning. So this means countries are taking steps to see that as we manage these people get to know how to also manage it alongside other diseases to ensure that diagnosis is done. So maybe Owen and another person could say that, but that's what I will say for now. Thank you.
All right. Thank you very much. Taking cognizance of the time that is really moved, and also acknowledging the lot of questions that are here that I think we need to pass this to the presenters to respond, and maybe we can share as soon as possible. But maybe one key thing that always comes with many projects is the issues of supply chain. I saw Alocia's hand is up, and I know he's a colleague of mine from the supply chain side. I just wanted any one of you to, what are the plans regarding really supply chain? Because when it drops, everything else drops.
And maybe Owen could comment on that. Thank you.
Yeah, sure. So, I mean, I guess there's, if we think about the supply chain, right, there's a number of facets that come in. You know, at the very top of this all, a lot of the raw materials that are going into the products are also going into other rapid tests that are in market. And right, these are some of the same suppliers that are offering malaria rapid tests and others. And so I think there's a lot of concern that had existed, especially early on, about the supply availability. Now, the benefits of the last year and even just the last 6 months is that we have more products in market, quality assured products. If you look at just the WHO EUL list, there are now 4 assays that have WHO EUL, others undergoing review. So the first step is diversifying the supply that is available to the market, and ensuring that supply is priced in a way that's actually accessible. And so those tests, I think we're getting to the point, there's obviously usability differences, there's some small price differences, but a lot of countries are using them somewhat interchangeably. And if you look at the procurement across countries, there's close to 40% of countries that are procuring over 2 different products, maybe 3 products, and distributing those across country just based on the interest or the needs at different settings. So I think from that side, there is sustainability, but we have to still stay on top of it as we get closer, or if we get close to another wave. But just in country, right, there's a lot of PSM processes that will delay these timelines. And so we've heard a lot about site-specific stockouts because of the tracking and the information that's shared back centrally where procurement decisions are being made. And so I know and probably a lot of you on the call right now have been working on those systems, trying to ensure that there's adequate tools and tracking available. So as sites are getting low on supply, they can request early and put those orders in. So I think there's a lot of things that are in place, a lot of things that are continuing to happen. But the last, from resourcing, there's obviously, Fatim can comment on the C19RM funds that have been available up to this point. And a lot of countries are shifting, right, to some degree of domestic procurement, and we're seeing volumes for both domestic and even private sector procurement as ways of ensuring that there's additional funding going into procurement and ensuring that there's continued availability. So across those three different parameters, I think we're in a good place, but we still have to push, again, more suppliers so that we have a diverse and competitive market, the tools so that countries are able to track and get the supplies needed when they need, and we don't have risk of stockouts. And then the last piece on resourcing, trying to think broadly, so we're not just dependent on one financial mechanism, but we have different resourcing if possible, so that we can have a diversified resourcing system. So yeah, I'll end there, but thanks.
Thanks, Owen. Recognizing that we've just gone beyond the hour, let me call upon Mr. Ndlovu, the CEO of ASLM, to just give us a few closing remarks.
Thanks, Anaf. Can you hear me and see my video?
Yes.
Okay. Okay. So colleagues, thank you so much for being part of this session for the last 60 minutes. I know it's not easy. Every time and again, we are always pulled from one video conference to another, but I think this has been very exciting and very engaging. And also I'd like to really thank the presenters for a job well done. So I'm just going to be brief in my closing remarks and really wants to highlight two things about this project and the support from Global Fund under the stewardship of Africa CDC. Number one thing that really strikes me is that this project has been put together using a bottom-up approach, not a top-down, but a bottom-up approach. And I think that's been very excellent. And I want to appreciate Global Fund even for that flexibility and also really working with what the country needs are looking like. I know at that time last year in December when this project was being defined, things have evolved, and I'm sure that flexibility is also there. As I saw that in some of the presentations, there are going to be some deep dives that are going to be done, really to narrow down to what are the current issues that needs to be addressed by this project and build upon some of these existing efforts. We are cognizant that there are so many partners, so much effort that has been done. So I really want to appreciate that. Secondly, and lastly, is the partnership that really is in this project. As you can see from this slide, we have Africa CDC, we have got ASLM, we have got CHAI, we have got APHL, and of course, the support from Global Fund. I believe this is a partnership that is meaningful. And not only at the regional or international level, but even it's coming down to country level where we want to work closely with the ministers of health, technical working groups, the COVID-19 task force, even the local partners as exemplified in some of these slides. So really, I think this kind of approach really will address, I think, one of the greatest challenges, the issues around sustainability, building capacity and living capacity even within the ministers of health. So with those remarks, really, I want to appreciate the team that really set up this webinar, Nafi and team. Really, thank you so much. And I really want to appreciate all the partners that were here today. So from myself, really, I look forward to ASLM, to CHAI, to APHL, of course, under the stewardship of Africa CDC with the support from Global Fund, really taking this interaction, I think, beyond this webinar, really expanding and really looking forward to be interacting with many of you as we come to these countries. So thank you so much, and thank you for taking this time, and have a wonderful day. And over to you, Anafi.
Thank you, Ndlovu, for the remarks, and thanks again. Within your remarks, you actually even addressed some of the questions that were in the chat. Colleagues, I can't thank you enough. I can't thank the presenters and everybody who got involved in making sure that this is a success. And without you, I think these webinars will not be successful as well. And I'd like to just end on the same note that I started, really quoting again the WHO Director General that until until the, what did he say? Until it is over, everywhere, it is not over for everyone else. So with these few words, please look out for, I think, responses to the many questions that have come through that have not been responded to. We'll try to make sure that these are done as soon as possible. On your screen is a code for those that have requested that would want to go to the ASLM Academy website and download evidence of them having spent the last 65 plus minutes. Thank you again for staying even beyond the hour. We look forward to meeting you in our next sessions. Please look out for the next few announcements coming soon. With this, good afternoon, good morning, and good evening to those that are in the Far East. Bye.